In the next 20 minutes or so, I'd like to take you along in my personal journey in quality improvement in pediatric CT dose management, illustrated on cardiac CT angiography. When I was a resident in Amsterdam, we were taught cross-sectional imaging is ultrasound. That is the only imaging modality you are ever going to need rather than anything else. And I was taught by Dr. Julian Puileit in the graded compression technique to make this diagnosis. 15 years later, I found myself as a pediatric radiologist at Mass General Hospital, and I found that this is the institution where the focused appendiceal CT papers originated from. It was a simple concept to give some rectal contrast and see if the contrast enters the appendix. Later on, it was found that sometimes the indication wasn't all that clear for appendicitis. They may have had a pyelonephritis or appendicitis, so we extended the scan to the whole abdomen rather than do a couple of slices to the right lower quadrant. And we started using it for inflammatory bowel disease, even non-specific abdominal pain, and sometimes I see scans being performed for turn out to be constipation. So the use of CT has tremendously increased, as this slide shows, over the years that I have been working in this field. And you can see the red is the part of the radiation exposure that comes from CT that has increased over the years. It's estimated per capita effective dose. And I've looked at our own utilization at the Mass General Hospital over a period of time, and it's gone up as well. You can see the different parts of it, the MSK, the chest, and particularly for the body imaging, it's gone up as is shown by this particular curve. So I have tried then to try to get a handle on this increase and see what it means. How can you quantify that? What can you do with that information? So the CT utilization went from 334 to over 1,200 scans per year at Mass General alone, an increase of 280%. And then I tried to come up with a formula to calculate the risk of lethal tumor induction per year, which is this formula, pretty simple. It's a CT utilization times the risk per dose times the dose per scan. And this was 10 years ago, and we had the CTU we could get it from our medical records as a function of age, gender, and scan area. And then the risk per dose was based on the information I had available at that time, also a function of age, gender, and scanned area. And then the dose per scan was at that time 24 milligram before the institution of dose reduction and 14 milligray after that. So I summed all these values together and I got the following curves of organ-specific tumor induction, just to get a handle on what we were doing at MGH. Complicated, many curves here. I'll illustrate one. Male, other solid tumors. A risk estimate went up from 0.2 to 0.6 by 190% of cases per year induced from our practice, presumably. Digestive tumors for females went up by 250%, the risk, half a case per year induced, presumably by the CT. And then the thyroid, it was a reflection of our population. We had more males in our group than females, even though females are more radiosensitive for the thyroid. But again, a significant increase of 420% over that time period. And breast tumors in females here, also 250% increase. So we then added all that up and came to the estimated total tumor induction, which went from 0.7 to 2.5 cases per year of our practice at MGH. And then if we applied reduced dose in all of those cases after it was instituted, we could cut that down to 1.5 cases per year. So there's something to be gained there. So this was our summary that I presented at RSNA of all the 11,000 scans that we performed in that time interval, and we came up with 20 estimated solid tumors induced. With dose reduction, that is a little bit lower, and average risk per scan is 0.2%. That's a familiar number that we've seen all along. And it's just the input of this formula. If you input a certain amount of dose into this formula, and on the other end comes the result, you can say garbage in, garbage out. So if you have a model, this is just a model. It is not a presumption of what it really is. We didn't really know what these patients were getting. We just added the dose as we knew it at the time. And that is the flaw of this way of thinking. It is not an observed variable, it's just a model, it's an estimate. That's what we have to realize. And I tried to publish this, but I ran it by Dave Brenner, and he said, well, you can never get this published because you use CTDI values and you don't use effective doses, and nobody's going to believe you. And that was the end of that, so I never got it published. But at least it gave me a handle of what was going on in our practice, and it gave me a way of thinking about it. And the study actually got published many years later by the group of Rebecca Smith-Bindman, which was referenced before, and they looked at the California experience over a longer time period. They used the effective dose, and they predicted 1 cancer per 350 abdomen scans, leukemia 1.5 per 10,000 head scans, and then they extrapolated this again to the whole of the United States. And this is what hits the headlines of the newspapers, the 5,000 future cancers. And again, it is a model. It's not an observed variable, and we have to be very careful with these interpretations. Yet it is a very important study, I think, because it shows that there's a large variability within the California healthcare centers, and if we cut the highest of the 25% of the doses, that would cut down 43% of this parameter, that we don't know if it's real, but it's something that we can use to get a handle on the situation. So they are projections, they are not observable variables. How many strikes does it take till we are out? This is the title of an article by Tom Slovis, Keith Strauss, and Don Fresh. And regarding CT dose, I didn't know what I was doing at the time. We were more like deer in the headlights of an ongoing car. We didn't have a clue that we didn't know the dose, and we didn't worry about it. Absolutely clueless. Strike one. I didn't know, but how can you know? The only way you can know is to measure something. If you can't measure something, you can't understand it. If you can't understand it, you can't control it. If you can't control it, you can't improve it. That's a mantra of one of these business tycoons that published this particular book. So I set out to do a real measurement rather than an extrapolation, rather than a theory based on the linear no threshold. I wanted to measure what was the actual dose on patients. And this is part of quality improvement process that is published in this book. There's many studies from the industry. Motorola, Toyota has used certain processes. And now CT radiation is a quality metric that's being used nationally and internationally. So we just measured the dose on the actual patient. That was our goal. And we did this with a dosimeter that you can stick the dosimeters right on the skin, and I did it at the level of the breast in CT angiography. And this is probably the most important slide in my whole lecture, because this child, a 3-month-old, 10-kilogram male with ventricular septal defect, this is a shaded server edition, and it carries an important message on that is happens to be radiopaque. Mommy loves me. And that is the parents trust their most valuable assets to us on a daily basis, and they expect us to know what we're doing. So that's the whole purpose of this. We need to know what we're doing, and we need to measure and quantify, otherwise we don't know what we're doing. So right chest CTA, radiosensitive tissues are there in the breast, the lung, the bone marrow, the thyroid, and they have a relatively high dose, as evidenced from this paper of Hollingsworth, pediatric cardiac CT angiography, assessment of the radiation dose. If the settings are really high, the highest settings that are at the time used at the time, 28 millisievert per scan, and up to 20 centigrade, that is 120 milligray breast dose. Now these are the highest end of the settings, of course, and this was many years ago, so we have really made significant improvements in this as well. And this is an example of our practice in the initial phase, 13 years old, 115 kilogram retrospective CT. And here, a couple of years later, with prospective cardiac triggering, we compared this with the amount of mammograms that the measured dose on the skin is equivalent to. So 1 mammogram is equal in our institution of 1.5 milligray, and then I compared the measured dose and expressed this in number of mammograms. We also calculated the effective doses of all of these, and we can see an improvement over the years. So then I realized that we had to do a correction of the CTDI for pediatric body side, because at the Siemens scanner at the time, all of the dose values that were displayed on the console were in reference to the large dose phantom. And this was actually hidden in the manufacturer's manual somewhere that our physicists pointed out. We had, for 80 kV, we had to multiply the CTDI by 2.3, and for 100 kV by 2.2. So the measured doses that I had on the skin were a factor of 2-3 higher than the CTDI doses. And I didn't quite know what to do with it, but now I understand how it works, because we have, literature came out, and we know now much better what we're doing. So I did that correction of the measured dose versus the surface dose versus the CTDI. And once you do the correction, the curve shifts a little bit, and that is for the group under 11 years old. And for the older age group, no correction was required according to the scanner software. So we have a correlation curve between the surface measured dose on the skin and the CTDI as it displayed on the console. Very good correlation, and some adult cases as well included. But then we realized that this volume CTDI is not a good application of patient dose, thanks to the efforts of the physicists who published the size-specific dose estimate measure as a better estimate of dose, patient dose. And we learned that we had to use correction factors that are individualized based on the diameter of the patient. So here are the tables that we have seen before, and for a patient who has an effective diameter, which is calculated by the square root of the lateral times the AP, we had to apply this correction factor of the CTDI volt times 2.4 in order to get a better estimate of the patient dose. So we go back to our young child, the 3-month-old, 10-kilogram baby with ventricular septal defect and pulmonary hypertension and asymmetric lung perfusion. And we did the measurements. We measured it on the skin. We measured it directly. We correlated. It was in the order of 1 mammogram worth of radiation exposure over the skin. We got tremendous information from CT, which is really the strength of this technology, showing the lungs, showing the pulmonary vein stenosis, showing the pulmonary hypertension, and the ventricular septal defect. So the CT technology is of extreme value for cardiac surgeons and others who have to treat these patients, and there's no question about that. We have to know what we're doing, and that's why we're doing these measurements and tabulations. So we're doing these cross-sectional diameters of the patient. We calculate the effective diameter, and then we multiply the CTDI dose times 2.4 in order to get the SSDE dose, and then we correlated the SSDE doses with the measured doses of the skin, and this is a perfect correlation with almost 1 coefficient and a high correlation coefficient, as you can see here. And this is over a large spectrum of scanners over a 5-year interval of time. 4 different scanners were used, going up from 16 slice to 64 slice to dual source to flash. And this is a data summary of all our dose measurements, and the details are not that important. It's important that each step of technology that we went up, the dose values were significantly lower than the step before. So the technology keeps improving, as you can see here. From 64 slice to dual source, from dual source to flash scanning, significant decreases in all the dose parameters that are measured and tabulated. To look at the diameter of the patient as well, they went down between the 2 scanners, so that can explain partially the reduction of dose. But between dual source and flash, the effective diameters actually went up, and despite that, the doses went down. So the technology keeps evolving and keeps moving us forward. This is another way of illustrating the same issue. The SSDE, the dose of the patient versus the effective diameter for the 64 slice group. The dual source slice group had slightly lower diameters. That may be partially responsible for the lower doses that we recorded. But once we went to the high-pitch flash scan, despite the patient being larger on average, they still had a significantly lower dose and a narrower range of doses as well. Very significant. So we go back to our coronary CTA dose and see the progress that we've made between 2006 and 2011 on a 14-year similar patient. We looked at retrospective cardiac triggering versus flash. We looked at the CTDI, the DLP. We converted it to SSDE, effective doses, and you can see this tremendous reduction in dose. Initially 29 mammograms worth of radiation versus 2 mammograms worth of chest radiation. That is quite remarkable. And so now with the flash CT scanner, we can see in this patient with an anomalous coronary artery. Yes, we did acquire this image, and it was one of the lowest doses that we ever recorded, 0.10 millisievert. And we found this was not quite acceptable. It was too grainy. We couldn't really tell the takeoff of the coronary artery. So we just called the patient back for another scan. And sure enough, with a better contrast bolus, but also with better technique, we can see the takeoff of this coronary artery much better. And this is the one where I did the measurement, and only 0.2 mammograms worth of radiation exposure for this very important clinical finding of a coronary artery anomaly that needs surgical repair. So in conclusion, we found that the SSDE is a valid measure of CT dose not just in the lab, not just with phantoms, but on actual patients doing clinical measurements as we were doing this for some time, over a very wide range of scanner platforms, techniques, and patient sizes. And we had patients that were overweight, adult size, and we had patients who were premature babies. So a tremendous range. That is the range that we deal with in pediatric radiology. SSDE should be used to model breast dose and other organ dose, and to document the results of dose reduction strategies over time, which we did. We were able to document this in our practice, how we have improved. I want to share this case with you as well that I wasn't directly involved with. 5-month boy with Williams syndrome. And this patient underwent preoperatively a coronary CT angiography. The cardiac anesthesiologist who sedated the child had some difficulty intubating the patient. We see some atelectasis. And we see that the scan didn't come out that well. It's mainly opacification of the pulmonary arteries, but what we were most interested in was the coronary arteries that was kind of missed by the bolus timing technique. And I'm sorry to say, but this was the only lethal CT that I've ever been involved with in my career, because the patient died within a few minutes after this acquisition of a cardiac arrest, despite being under the care of a cardiac anesthesiologist. And I went back to the CT scan 2 years before in the same patient, and I found that it was slightly better coronary opacification here. And I can see that the coronary arteries are perhaps a little bit difficult. There's a lot of motion artifact here, but one could say perhaps there is some narrowing at the orifice here. And also on this coronal image, you can see that there is some origin stenosis as part of the supravalvular aortic stenosis. Also on the shaded surface rendition. So coronary artery disease with anesthesia-related death, death can happen in children with Williams syndrome. And this is published in the literature. It's extremely rare, but it is a very unfortunate event for all of those that were involved in the care of this patient. This was really a terrible situation. But the anesthesiologist went on to publish this case in their literature and concluded that it was perhaps a combination of anaphylactic reaction. Autopsy didn't confirm any of that, or perhaps a coronary artery problem. So this brings me to one of the take-home messages, the benefits versus the risk of CT scanning. First, do no harm. Death from a diagnostic procedure is never acceptable, and that is very clear when it comes to this cardiac death from this Williams syndrome. But then what about the validity of the radiation carcinogenesis and the linear no threshold theory? We had a lot of arguments in this meeting, pro and con, very strong opinions were being voiced. I don't have a particular opinion on it. I don't belong to any religion when it comes to this. I don't answer to any pope or ayatollah. I just try to keep up with the literature and see what's going on in this field. And there's a tremendous body of literature out there. And that's why I go along with others who say we have to just come to consensus in this field, rather than voicing strong opinions. So I want to quote John F. Kennedy in reference to the atomic bomb results and the exposure. The number of children and grandchildren with cancer in their bones, with leukemia in their blood, or with poison in their lungs might seem statistically small to some in comparison with natural health hazards. But this is not a natural health hazard, and this is not a statistical issue. The loss of even one human life, or the malformation of even one baby, who may be born long after we are gone, should be of concern to us all. Our children and grandchildren are not merely statistics towards which we can be indifferent. This is a slide that shows, I like to show us the technology, the CT. How can it save us? Maybe it saves a patient out of a very difficult disease. Maybe it saves a physician from the malpractice lawyers circling around. I mean, it can symbolize several things what's going on here. It's a very telling image. So what are the drivers of CT use in this country? It's a technological innovation, more indications, fewer sedations. We have tremendous applications of CT that have come along over the years. It's really very grateful to be involved in this development, to be part of that, and we all care about CT, we're passionate about CT, and we want to do the best to our patients. But then there's defensive medicine, which leads to patient and physician expectations of 100% certainty, the rule-out culture that I see around me sometimes. And an offspring of that is the Munchausen by proxy disorder, where children are taken from hospital to hospital for more and more imaging tests by their parents, a form of medical child abuse. And then there's healthcare economics that drives the increased availability of CT scanning. The fee-for-service model, employer-paid insurance that drives the payments, the high cost of hospitalization. So it's easier, it's faster, it's more cost effective to do a CT scan and discharge the patient quickly from the emergency room rather than admit him to the hospital. And then there's the hidden, what I would like to call the hidden conflict of interest of the radiology profession. We are passionate about CT in this room, but we all have our livelihood dependent on the revenue that's generated by CT. And that is a fact that I think is not very often emphasized in the literature. So what's the role of decision support? It can bend the curve a little bit. I'm convinced of that. This is data out of Mass General, and there's a bigger national trend going on. The national trend is that there is a decline in annual utilization of CT, which is probably not quite due to decision support, but the radiation scare, economic drivers, constraints that are within our system. So I'll go over this, and I would like to summarize with a white paper that was published by the ACI, Strategies for Radiologists in the Era of Healthcare Reform and Accountable Care. What can we do in the future? What are our future professional challenges? Pediatric radiologists should be regarded as consultants rather than technicians. Could we be using a gatekeeper role? Is there reimbursement possible for non-interpretive skills in this field rather than just reading scans? Acknowledge our hidden conflict of interest, be conservative with written recommendation for follow-up, and embrace our role as expert in the use of ionizing radiation for diagnosis. Call ourselves proudly radiologists rather than imagers. And if we don't regulate our own profession, others will. So what have I learned over the years? Correct pediatric CT dosing is tricky. There's a wide range that we care for, premature infants to obese adolescents. We cannot trust the scanner console dose. We have to measure something. CT is extremely valuable, but it can also harm. Quality assurance is teamwork. I've had the privilege of working with great physicists and other experts in the field. And attention to detail is important, but keep the big picture in mind. Can you see the big picture to the forest? I think that's